Okay, excellent. It remains for me to be extremely grateful for Takeda to invite me to participate in this annual Saudi Hematology Congress, and I'm honored to be amongst the experts in hematology from the Middle East, some of whom I've met quite recently. It is an absolute pleasure to join you again. I'm Johnny Mahlangu. I'm from Johannesburg, the Charlotte Maxeke Johannesburg Academic Hospital. I'm going to take you through my thoughts on the new standard of care in hemophilia, achieving treatment and prophylaxis goals with Adynovate. Next slide, please. It looks like I've lost my control here. There you are. These are my disclosures. They just reflect my interface with a fairly large number of players in the clinical trials field. The agenda is fairly straightforward. I'm going to highlight the evolution of therapies in hemophilia A management, which we're all familiar with, and perhaps highlight the prophylaxis as this new standard of care in patients with hemophilia. I will review some of the safety data from pegylated products. So this is, I must admit, is a summary. I mean, it's a talk on its own. And I'll also share with you some of my thoughts on the risks and reasons for shifting patients from one product to another. And finally, I will touch on the role of Adenovate in the management of hemophilia A patients. Just to remind you that the clinical hallmark of our patients with hemophilia are intra-articular bleeds, otherwise known as hemathroses, as shown by the left knee swelling in this patient of ours. In a subset of patients, the swelling evolves into a vicious circle of bleeding, leading to more bleeding, the so-called chronic synovitis, as shown in this left knee here. Chronic synovitis quite naturally often leads to musculoskeletal damage, specifically the damage of cartilage and bone, leading to both structural and functional dysfunction in the context of patients with hemophilia, leading to hemophilic arthropathy. And the good news is that all of this cascading can actually be stopped, slowed down by the use of replacement therapy. We do know that replacement therapy, in fact, is the treatment of choice for patients with bleeds. In the last several decades, we have seen this unprecedented evolution of these therapies, starting with the use of whole blood in the 1940s, and then we switched over to fresh frozen plasma in the 1950s. The use of cryoprecipitate, which unfortunately still persists in some parts of the world, in the 1960s. That's when Judith Poole, in fact, invented, at least discovered cryoprecipitate. And then we moved on to concentrates. In the 1980s, we started off with plasma-derived clotting factor concentrate, and then later in the 1990s, we invented the recombinant clotting factor concentrate. And of course, the good news with replacement therapy, it has allowed us to have a different approach to hemophilia care. It has given us a paradigm shift in care from a reactive approach, which is usually an on-demand treatment given when the bleed has already happened, to a proactive approach, which is the prevention of the bleed before it happens, otherwise known as prophylaxis. And I'll spend, in fact, most of this talk talking about the pros and cons of prophylaxis. Let's start off perhaps by just giving you a high-level summary of some of the benefits of prophylaxis. We do know from the early studies in the 1990s that prophylaxis leads to less clinical and radiological deterioration of joints. That has been demonstrated through joint scores as well as imaging. We do know that in the context of the young individuals with hemophilia, they lose fewer days from work, and the adults you lose fewer days from their work environment if they are on prophylaxis. There are many other benefits. There is a 6-fold reduction in joint damage in those patients on prophylaxis when one is looking at the joint damage using MRI. There is a 7-fold reduction in the number of bleeding episodes per patient per year. This is a summary of the data from the Markov-Johnson study, the landmark study that was published in the NEJM in 2017. There is an increase in physical activity on patients on prophylaxis, and of course preserved bone mass density in this grouping of patients, and that was shown some time back, almost a decade ago. So there are many benefits of prophylaxis, and we do accept that, in fact, in an ideal world, all of our patients should be on prophylaxis. But the bottom line is that despite us accepting prophylaxis as the standard of care, there are actually unmet needs associated with the use of standard half-life in the context of prophylaxis. And I'm giving you an example here of a typical graph showing a patient who is on a standard factor 8 half-life product, showing the peaks and the troughs. The troughs obviously represent areas of inadequate bleed protection and therefore areas of risk of bleeding for these patients. And the reality, in fact, is that by and large, these patients do have bleeds. This was clearly demonstrated by Kraft and colleagues who examined joints, and they looked at the reportable lifetime number of clinically detectable bleeds as a function of an MRI score. What was quite remarkable here is a small number of patients who reported no bleeds at all, and yet the MRI score was indicative of some kind of joint damage. This has been given different terminologies, subclinical bleeds, breakthrough bleeds, but the bottom line is that despite prophylaxis, one of the unmet needs is that patients do have breakthrough bleeds. There are other unmet needs. If one is giving a standard half-life product, we do know that in a period of a week, one will have to be very diligent in giving those injections on a regular basis to raise the baseline factor level to a level that we believe is actually protective. In order to do that effectively, a large number of injections have to be given. A simple calculation indicates that if a patient is very compliant with 3 injections per week, we're looking at least 156 injections per year. And in fact, if the patient and their parents and caregivers are very compliant, by the time they turn 20, we're looking at more than 3,000 injections that the patient will need to be able to protect their joints through prophylaxis. And you'll agree with me, giving 3,000 injections carries a very high treatment burden. It is in this context of the unmet needs associated with the standard half-life products that the evolution of extended half-life, in fact, came into play. The extended half-life products have been particularly noted in the recent WFH guideline on management of hemophilia, the 3rd edition of the guideline. And in fact, the guideline came with a new standard of care, which is prophylaxis, largely informed by the impact of extended half-life products. The guideline states very clearly that prophylaxis is the recommended therapeutic modality over episodic treatment. And in fact, in the context of extended half-lives, there are many beneficial effects of using extended half-life for prophylaxis. And 2 of those, which are currently the unmet need, is that with extended half-life, one is able to reduce the frequency of injections, and consequently, one is able to reduce the burden of treatment. And you're also able to raise the trough level and therefore offer better protection for the patients who are likely to get breakthrough bleeds. when they are on standard half-life products. The reduction of the frequency of injection is illustrated in these cartoons. The bottom cartoon is the frequency of injection with an extended half-life. As you can see that in this particular example, there will be 1 injection as opposed to 3 injection with a standard half-life product to achieve the same trough level, which is protective, clearly indicating a reduction in treatment burden. If one looks at the goals of prophylaxis, the goals are actually to achieve, and not only achieve, but also maintain target factor level. In this cartoon, I'm showing the difference between the half-life of a standard half-life product and the half-life of an extended half-life product. And the most important element of this cartoon is that the difference between the two is actually huge, up to almost 60 hours, indicating, of course, that there may well be pharmacokinetic benefits for achieving and maintaining the target factor 8 level. And of course, there are many factors that influence the factor level, and I've listed some of these factors here. They include the dose of the factor that one is giving, the dosing frequency, the clearance of the product, and I'll talk very briefly about why some of these extended half-life have got a very lower clearance later, and of course the half-life of the product itself. It's the combination of these factors that ultimately will lead to optimum care of these patients when one is using extended half-life as opposed to the standard half-life. Now the question, of course, is what are some of the technologies that have allowed us to come out with extended half-life technology? In summary, in fact, there are 2 main categories of technologies. They include the fusion technology and the pegylation technology. The fusion technology has been applied to clotting factors, clotting factor 8 and clotting factor 9, using both the FC fusion and the albumin fusion. And I've given you examples of the studies that have been published in that context. The pegylation technologies has had several approaches. They include site-directed pegylation, controlled pegylation, and glycopegylation. And these are the studies that, in fact, have been completed. In the interest of time, I would not have enough time to take you through each one of these studies. Suffice to say that perhaps for the purposes of this talk today, I want to focus on pegylation. In particular, I want to make a distinction between random pegylation. What essentially it means is that the PEG molecule, as in the case of the BEX 8555, is attached randomly to the clotting factor protein, either on the heavy chain or on the light chain, and there can be 1 or more of these PEG molecules being attacked. This is actually distinct from the other 2 pegylation, the site-directed pegylation, which has to be specifically attached to the amino acids in the light chain of the clotting factor, and the case of the glycopegylation, where the PEG moiety is attached to the sugar on the protein. The distinction, of course, is important. Not that it makes much difference in terms of the ultimate efficacy of the clotting protein. And we do understand the mechanism by which pegylation extend the half-life. And I've summarized here some of the well-known mechanisms. The one mechanism is decreased glomerular filtration. The proteins that are carrying the PEG moiety will then increase the hydrodynamic volume of the protein, resulting in it not being filtered easily and being excreted through the urinary system. The second mechanism is the receptor-mediated clearance, which is decreased as a result of the PEG molecule being attached to the clotting factors. And the final one, the PEG molecules seem to be shielding the clotting factors from proteolytic degradation, and therefore the normal breakdown of these proteins, in fact, is slowed down, and in some cases, in fact, is stopped completely. With that in mind, of this pegylation and the mechanisms by which the PEG and the pegylation extend the half-life, I just want to remind you that the use of PEG molecules in hemophilia is not unique. There are many biopharmaceuticals in which the PEG molecules have been attached to the pharmaceutically active ingredient, and I've given you here examples of such molecules, and it suffices to say that in fact by and large there are two characteristics here. Most of these conditions look like they are in fact hematology conditions, and the second component is that almost all of these conditions have an element of chronicity, just like hemophilia patients have got a chronic condition. And the reason I'm pointing that out is the concern, of course, that giving a PEG molecule once or twice makes no difference, but if you're going to give it for a longer period, it may well have a deleterious effect. We don't have evidence for that, and in fact there has been a number of preclinical studies as well as clinical studies that indicate that the presence of a PEG molecule in fact does not result in an increased toxicity. I'm showing you here the data from Adenovate in the clinical context, just to give you an indication of the level of the PEG molecule when one is giving standard doses of factor 8 in the region of 60 to 100 units per kg. You can see that the PEG exposure in milligrams is well below 1 milligram in the majority of these patients, even in the context of patients undergoing surgical procedures who require to have the PEG molecule to be given on a daily basis. The reality is that in fact the exposure remains very, very low. Just bear in mind that overall we're looking at 0.095 micrograms of the PEG molecule per unit of factor 8 that we give to the patients. Very, very small indeed. And of course, one could never complete the story of the PEG molecule without looking at the toxicity studies. In the preclinical settings, there's a lot of studies, and I've chosen one of these studies by Stidl and colleagues, published in 2015. And what it really shows is a variety of PEG sizes ranging from 4 kilodaltons to as high as 7,500 daltons. If one looks at the dose, very variable as well, ranging from 90 milligrams per kg to 1,250 milligrams per kg every 4 weeks, at least every day for 4 weeks. The models used range from the rabbit to the rat to macaque to the dog. And ultimately, what we're interested in, what were the toxicities? In fact, in the majority of these studies, at least in the majority of the dosing regimens that were used, one could not see any adverse events. In a small number of patients, so at least the rabbits, one could see the clouding of the renal tubular epithelium, as well as the hepatic parenchymal changes. These changes, I must admit that the changes were seen to be reversible, and certainly these changes could not be reproduced in the non-human primate environment when these studies were repeated. How is the PEG molecule being metabolized? It is metabolized through a number of standard metabolism routes. The one route, perhaps the smallest of this route, is it being taken by the reticuloendothelial system, by the macrophages, and then it gets broken down and of course gets released into the circulation. The other mechanism is through the liver. In the liver, it gets excreted into the bile. A small proportion of this gets excreted as peptides and amino acids into the circulation. In the bile, it is released through the feces, and then in fact, that is very, very effective. The majority of the PEG is metabolized through the kidney. In the kidney, there is glomerular filtration that happens, and the consequence, of course, is elimination in urine. and that is the bulk of the PEG molecules that we see being taken out of the body over time. And of course, the second and perhaps most important question is the question of immunogenicity of these products. If one looks in general at extended half-life products and standard half-life products, and the question we can ask is there any risk of switching patients from one product to another? And I just want to share with you at least 3 studies, Canadian, Irish, and the UK experience. These are real-life experiences on switching patients. Let's start off with the Canadian cohort. This was switching from a plasma-derived factor VIII to a recombinant factor VIII in 478 non-inhibitor patients. They were switched using to a first-generation recombinant factor VIII. They were followed up for 2 years, and the bottom line here is that there was no increase in risk of inhibitor development, which is very much reassuring. But you could argue that it was a switch between a plasma-derived and a recombinant. In fact, the Canadians did it again. They specifically looked at switching from a recombinant factor VIII to a different recombinant factor VIII in 274 non-inhibitor patients. This was a second-generation recombinant factor VIII product. Follow-up was for 2 years, and they demonstrated that, in fact, the inhibitor rate was not increased when you switch from a recombinant factor VIII to another recombinant factor VIII. If one looks at similar results from the Irish cohort of 96 patients, you can see that, in fact, a similar picture emerged in previously untreated patients when they were switched. In fact, the inhibitor rate was extremely low in this cohort of patients. And the final results that I want to share with you is, does it make any difference if you are switching from a modified factor VIII to another modified factor VIII? Take, for example, a full-length recombinant factor VIII, and you switch over to B-domain deleted recombinant factor VIII. That was carried out in the UK in 1,100 patients. 561, in fact, were switched, and 682 were not switched. You can see that, in fact, switching over from a full-length to a B-domain deleted recombinant factor VIII was not associated with an increased risk of inhibitor development. And I hope with this data set, at least data sets, I have convinced you that switching does not carry an increased risk of immunogenicity. As you know, the most feared complication of hemophilia is the development of inhibitors. I want to switch over now to ask a simple question. In our environment in Johannesburg, who do we consider for switching from one product to another? And I've tried to summarize here what we normally use as guidance. And of course, this can be expanded as much as you want to. In the interest of time, I've stuck to 4 guidance principles. And the first one is, we do want to switch someone who's experiencing a high treatment burden on replacement prophylaxis. Someone that access or and may well take some strain in injecting themselves. Reducing that treatment burden is absolutely important. As I indicated earlier on, you might just bring down the number of injections from 156 to only 52 if you are injecting once a week with an extended half-life product compared to the standard half-life product. We do want to switch those individuals who have target joints in which, in fact, we are aiming to reduce the annualized bleed rates. You could argue that, in fact, that applies to every patient. I might argue that it probably doesn't apply to every patient. There will be some patients who have very low bleed rates who actually do not need to be switched, who are satisfied with where they are. The bulk of the patients, depending obviously on their physical activities, their preference, etc., may well need to be switched, particularly if they are having target joints. And that is actually the next criteria that we use, target joints as defined universally by a number of joints in a certified period of time. If patients develop target joints, we automatically put them on prophylaxis. And if the prophylaxis they are on does not allow the target joint to resolve, we then switch them over to a different product, hopefully a product that is much more effective. And the last consideration that we take into account is patient preference. It is increasingly important to take into account what the patients want, and often it's not given that what the patients want is what they will get, but we do take into account that, in fact, if patients prefer to be switched over to the latest technology, to the latest products, we do actually encourage that, and we do want them to take advantage of the benefits of the new technologies. And the question then arises, what can Adenovate offer? And I've taken the liberty here not to give you all the studies that have been performed, but to give you high-level data on Adenovate with regard to its pharmacokinetics, efficacy in terms of treating bleeds and preventing bleeds, efficacy in terms of surgery, and of course overall safety, which is extremely important in many of these products that we look at. Let's first start off by summarizing the pharmacokinetics, and the most important parameter here is the half-life, shown in gray here, compared to Adenovate, which is a standard half-life product, showed in black. You can see the difference in half-life is huge. It is at least 1.4-fold higher, longer half-life with Bex 855, which is Adenovate, compared to the Adenovate, with a half-life of less than that. If one moves over to the treatment and the prevention, and I've taken the liberty here to combine a number of studies, the pediatric study and the study conducted in adolescents and adults. You can see that we're talking about a reasonable number of patients. Adolescent and adults, 137 patients, pediatric with 66 patients. The majority of these patients received a single injection. In the context of adolescents and adults, 85%, one injection resolved the bleed, compared to 90% pediatric, where a single injection resolved the bleed. If one looks at those patients requiring 2 or less injection, the number of patients in the context of adolescents and adults rose to 96%, compared to 91%, which were resolved with 2 injections. The annualized bleed rates on prophylaxis was low. By low, I mean lower than 4 bleeds per annum. For the adolescents, it was 1.9, receiving Adenovate twice a week, and 3 in the pediatric patients receiving Adenovate also twice a week, which is quite remarkable. I mean, those are the numbers that only became apparent when we started to use extended half-life. Even with ordinary standard half-life prophylaxis, these numbers, in fact, were very high in our patient population. What about the efficacy when Adenovate is used in the peri-surgical setting to control bleeds? We're looking here at 21 surgical procedures. In fact, all 21 of these surgical procedures were major surgical procedures, not minor surgical procedures. There were only 5 minor surgical procedures. During the conduct of all of these surgical procedures, there were no requirements for intraoperative injections. Essentially, the patients can get a preoperative dose and then be followed up in the recovery environment, where the next dose may well be considered. What about the hemostatic efficacy? It was very high, at 92%. This is now on a 4-point ISTH scale, 92% being good or excellent hemostasis associated with the use of Bex 855 in the patients undergoing surgical procedures. The most important element of any of these novel therapies is always the safety aspect, and I've taken the liberty here to summarize the safety profile of Adenovate. The number of patients exposed to Adenovate was 137. There were no inhibitor patients that were treatment emergent. In other words, as a result of exposure to Adynovate. None of the patients developed thrombosis, and no one died when they were exposed to Adynovate. There were a number of patients that developed anti-drug antibodies. These are non-neutralizing antibodies which had no measurable effect on hemostatic efficacy. And there were a number of patients, a total of 7, that developed drug-related adverse events. And I must admit that all of those adverse events, in fact, resolved, even though they were thought to be related to Adenovate. Something that obviously we need to keep in mind at the end of the day. I hope I have shared with you some of the evolution of the therapeutic landscape in hemophilia. I've also shown you the extended half-life products, how we switch some of these extended half-life products and standard half-life products, that there is no risk of immunogenicity. And finally, I've shared with you a set of data that shows that Adenovate, which is one of the extended half-life products, may well be an option that you need to consider when you are thinking about better care for patients with hemophilia. With all of that, thank you very much for your attention, and I'm happy to take questions.